Shall we start?
Yes, sir.
Okay, sir.
You see my slide?
Yes, sir.
Yes, sir. Yes, sir.
Yes, sir.
ECG normal values.
Moving?
Yes, sir.
Yes, sir.
Okay. Am I heard clearly?
Yes, sir.
Okay. Okay, we'll start. Today is going to be a very important day because the entire ECG basics is going to revolve around that, and everything ECG interpretation is going to revolve around this lecture today. That what is the normal value for each wave, each segment, each interval, like that. So if only you know what is normal, you will understand what is abnormal. You will be able to diagnose what is the abnormality in a particular ECG. So as usual, salutations to my Guru Dr. Chennappan sir. And this statutory announcement, stop me whenever I am not clear. And I would like you to be very interactive, at least from this class onwards, because today I will be posing a lot of ECGs to you, and I will like you to interpret. I will ask you to interpret and tell me the diagnosis. I want you to make a sincere attempt and speak out, admit yourself and answer, right? Try to make an attempt. You will definitely be very clear and very correct in this. So please be interactive today. So the first thing what we have to understand is the heart rate, how to calculate the heart rate. Now ECG, computerized ECGs will give the rate there itself. Many times it will be correct, but you must know how it is calculated. So it's a simple calculation. It is the 300 divided by number of big squares between two successive R waves in the same lead. For example, take any one particular lead, lead 1 or lead 2 or AVR or E5, E6, any one particular lead, and mark one QRS R wave, one R wave, mark the next R wave, and count how many big squares are there in between the first R wave and the next R wave. Suppose there are 3 big squares between 2 R waves. The heart rate is 300 divided by 3, it is 100. Suppose there are 4 squares in between, it is 300 by 4, 75. So that's all. It is a simple thing. Only thing is you should select the 2 R waves in the same lead. You should not take one in lead 1 and one in the adjacent lead in AVR. That should not be done. Same lead you must count, right? I'll show you examples, right? See, for example, this is the ECG. See how to calculate the heart rate. I told you to choose any one particular lead and mark 2 R waves. See, here I have marked 2 R. I have, for example, taken lead 1 and I marked 2 R waves. 1 R wave here. One R wave here and another R wave here. See, what I wanted to do is calculate how many big squares are there between R wave. How many are there? 1, 2, 3. Isn't it? Are you able to? There are 3 big squares between 2 orbits. What is the heart rate now?
300, 100.
100, sir.
100. That's it. That's it. 300 by 3 is 100. So the heart rate. That's all. It's very simple to calculate the heart rate.
हाँ, वो alternate days नहीं, 5 दिन के पास नहीं, daily.
Sir, what did you say? Okay. So this is what? Mark one or another mark, count number of squares. But the problem or the fallacy with this principle is calculation is it will give only some 4 or 5 numbers. For example, if there are only one square, 300 by 1, heart rate is 300. If there are 2 big squares, it is 150, 300, 475, 60, like that only. You will have 300, 150, 75, 60, 45. 30, like that only you will get the numbers. You will not be getting, it is an approximate calculation. This is not 100% correct. Sometimes in some clinical situations, you may have to be accurate. For example, you will not get a heart rate like 78, 92, 102, like that. You will get only these 5 numbers. So how to get the correct number? That goes by another formula, that is, instead of big squares, we count the number of small squares. Some number of small squares. Each big square has 5 small squares, isn't it? So count the number of small squares the same way between two orbits in the same lead. Here the calculation is 1500 divided by number of small squares. For example, here you have calculated 1, 2, 3 big squares. So you calculated the heart rate as 100. Whereas if you want to be very accurate, you have to count the
16
number of
small
these
squares.
small squares. Say how many are
16.
there? 5, 15, 5, 10, 15, plus 1, 16. Are you able to appreciate? So 1500 divided by 16 will give you the accurate heart rate for this patient. So this is the formula which you have to use. I'll show you some examples. Provided the speed, and I told you the standardization. If only the standardization is correct, all these calculations are correct. Always, all calculations are applicable only if it is recorded at the normal speed and normal standardization. Right. Say, for example, the heart rate here. Let us say lead 1. What is the heart rate here? How do you do? Mark one R wave, another R wave, and count how many small squares are there? How many big squares are there? Anyone please calculate.
4.
1, 2,
4, sir.
Heart rate is
4.
75.
Exactly. 4 big squares are there. Then the heart rate is how much?
75.
75.
75. So it is easy calculate, but it is an approximate number. If you want to be very accurate, how many small squares are there? 5, 10, 15, 20, plus
22.
small squares. 22. So what is the formula? 1500 divided by 22. I have worked it out for you. It is 68. So if you say the heart rate is 75, you are right. If you say it is 68, you are very accurate. That's it. That's how you calculate the heart rate. You got it,
Sir,
everybody?
how about 300 and 1500?
I didn't get you. Sorry. What is it?
300 and 1500, how do we get that time?
How do we
You-
get,
you
how do
told
we
about
arrive
the
at?
Speed
formula.
of the
Yeah. That's a constant number calculation,
Okay, sir.
Just blindly follow the formula. That's it.
Okay,
does it
okay.
depends upon the speed, sir?
Yeah, that's what I said. The speed should be correct. Speed should be recorded at 25 millimeter per second. Suppose it records at this rate of 50 per second, then everything will be doubled. You instead of 3 small squares, you will have 6 small squares, or 6 big squares, you will have 12 big squares, like that. It will be doubled. Everything will be doubled if you run it all. That is why the important caveat is said, provided the standardization and speed are correct. That's very, very important, right? You got it, sir? This formula, everybody? Any doubts for anybody? Right. Okay. What is the normal heart rate? Is 60 to 100. When the heart rate is less than 60, it is bradycardia. When it is above 100, it is tachycardia. You all know that. This is the correct rate. Sir, what is the heart rate here? Please attempt. I want you to be interactive. Throughout today, I will be asking a lot of questions like this. What is the heart rate here?
75, sir.
Very good. Very good. There are four big squares, so it is 75. Correct. It is 300 by 4, 75. Is it normal rate or brady or tachy?
Normal, sir.
Normal.
Normal heart rate. Very good. Right. What is the heart rate here? Have you so much of time? What is the heart rate here? How many big squares are there between two orbits?
150.
150, sir.
Correct. Heart rate is 150. Is it normal or abnormal rate? What do you
Tachy.
call it? You call it as a
Tachycardia.
tachycardia. Very good. It is a tachycardia. Very good. It is tachycardia. What is the heart rate here?
50 Brady, sir.
Exactly. 50 per minute. So what is the normal or abnormal?
Brady, sir.
It is a bradycardia.
Bradycardia.
Very good. I'll tell you subsequently how to call it as a sinus bradycardia, but it is a bradycardia for this type. Okay. What is the heart rate?
Uh, 75, sir.
75. Very good. When we
75.
when we say heart rate, we mean ventricular rate. You understand? When we say heart rate, it is only ventricular rate. But here, you see something in between, two R waves. See the previous ECG. There is one R wave, T wave, then another T wave, QRS T or PQRS T only. There is nothing in between. Whereas here, you see multiple things. What is this wave? This is one P, QRS T. What is this again? What is this again? What is this again?
P waves.
Multiple P waves, exactly. One P wave, another P wave, another P wave. You know, P wave represents atrial depolarization. So when you see multiple P waves between two R waves, you should calculate not only the ventricular rate, you must also calculate the atrial rate using the same formula. Here I told you what is the heart rate, and you all said 75 per minute. What is the 75? It is ventricular rate. But what is the atrial rate? How do you calculate the atrial rate?
150.
Exactly. One plus one. There's only one small big square in between, no? For example, let us take two, say here. This is one P wave. This is another P wave. How many big squares are there? What is the
One.
difference?
One big
One.
How many big squares are there?
One.
There is only one big square. So what is the
X-ray
atrial rate?
or blood test?
What is the atrial rate? So what is the difficulty?
300, sir.
Same thing.
150,
300 divided by
150.
number of big squares. What is it?
1 divided by
300
1.
divided by 1 is
300.
300.
300. So the ventricular rate is 75 per minute. Atrial rate is 300 per minute. Right? That means that is what we call it as a 4:1 AV block, like that. You will learn it later. So every 4 P waves, one QRS is coming. 1, 2, 3, fourth P wave only one QRS is coming. So 4:1 AV block. That's what. So what I mean to say is, when you are calculating heart rate, you are meaning ventricular rate. That means there should be one P wave followed by a QRS, one P wave followed by one QRS. If only that is it is enough if you say if the heart rate is 75, 100. But if you see multiple P waves, more than one P waves between two R waves, then you must calculate separately your ventricular rate and the atrial rate. That will give a very valuable information about our AV blocks. So here the ventricular rate is 75, atrial rate is 300 per minute. You got it, sir? Everybody?
Yes, sir.
Yes, sir.
Any doubts for anybody?
Yes, sir. Yes, sir.
I want you to clearly understand everything, and I want all of you to please interact. Anybody has any doubts?
No, sir.
No, sir. No, sir.
Only two no's. Okay, right.
No, sir.
Yes, sir.
No, sir.
Sir, there are only one extra P wave, right?
Yeah. No.
So,
This is a P wave. This is another P wave. This is another P wave.
so T wave is
This is the
absent.
T wave. This is the T wave.
Okay,
Small
inward.
negative
Okay.
deflection is which follows the QRS is the T wave.
Okay.
This is the T wave. This is the T wave. This is the T wave. Upright.
So-
Positive wave is the P wave.
So for every 3 P wave, there is only one QRS complex.
Exactly. So atrial is
Okay,
beating independently. Atrium is beating independently at the rate of 300 per minute. But ventricles are responding on the rate of only 75.
Okay.
That's what you understand.
Okay, sir.
Each pacemaker, I told you what is a pacemaker, is one which produces an electricity and creates an impulse. So atrium is beating independently. ventricle is beating in there is no relationship to each other at all. That is what it means. Got it?
Yes, sir. Yes, sir. Clear.
Okay. This rule will apply only when the rhythm is regular. What I mean by regular, the RR interval, the interval between one RR is the same as the next RR, is the same as the next RR, same as the next RR. If the interval is exactly the same between each R wave, then we call it as a regular interval or regular rhythm. So this formula of 1500 or 300, all those formulas will apply only when the heart rate is regular. Suppose we find many situations where the heart rate is irregular. For example, atrial fibrillation. You find irregular rhythm. Different, one QRS, suddenly long pause, another QRS immediately, some gap. So like that. That is typically what happens in atrial fibrillation. When you have like this, then you cannot apply this formula. Then you have a different formula there, right? See, for irregular rhythm, what you have to do is simply count the number of beats. Previously, we were counting the number of squares between the beats. Now here, you count the beats. How to count? Count the beats, number of beats present in the 50 big squares. 50 big squares. What is 50 big square? What is the duration of 50 big square? You all know one small square is 0.04 seconds, I told you. So one big square has 5 small squares. So one big square is equal to 0.2 seconds. 5 into 0.04 is 0.2 seconds. Suppose 50 big squares, 50 into 0.2 is 10 seconds. So your entire ECG, if you count 50 big squares, that means that amounts to 10 seconds of recording, 10 seconds of the events that is happening. Right? One big square is 0.2, 15 to 0.2 is 10 seconds. So just count the number of beats present in the 10-second ECG. So that means you calculate how many R waves are there. Suppose there are 10 R waves in 10 seconds. What is the heart rate per minute? For 10 seconds, 10 beats. For 60 seconds, what is the difficulty?
Into 6.
Into 6. Just multiply by 10 seconds. For 10 seconds, 1 minute is 60 seconds. For 10 seconds, we have calculated how many times the ventricle is beating. Say, for example, 8 times is the ventricle that had been beating for 10 seconds. Then, if it is 8 beats per 10 seconds, for 1 minute, multiply by 6, you get it for 60 seconds. 48. That's it. So that is how you must go for the formula. But the advantage is here is the biggest advantage is you need not count 50 big squares. It is very difficult to calculate, count. Normally, most of our machines record only 10 seconds of ECG paper. They record only for 50 big squares. That is, from beginning to end, if you count, it will be approximately 50 to 52 big squares. So you need not count 50 big squares. Just count how many QRS is there from the beginning to the end. That means it is a 10 seconds recording. That is why ECG is called a 10 seconds wonder. Why? Because it records the 10 seconds events. For example, see here. See, this is a regular rhythm or irregular rhythm. Can somebody say? See the RR interval. See this RR interval. See
Irregular.
Irregular, sir.
Everybody agrees. Everybody is able to identify it as irregular rhythm. Then your original calculation will not apply here. 300 divided by big squares, 1500, that application will not happen here. Here you must apply a different formula. So what you have to do, just simply mark the first QRS, mark the last QRS. First QRS, then count in between how many QRS is there. How many QRS is there? From here to here,
30.
if you count, it will be 50
30.
seconds. It will be 50 big squares. From here to here, if you count, it will be 50 milliseconds. 50 small square, big squares. That means it is a 10 seconds recording. 10 seconds recording. So how many QRS is there? 1, 2, 3,
13.
13. Exactly. So for 10 seconds, from here to here, 10 seconds, the ventricle has beaten for how many times? 13 times. So what is the heart rate per minute then?
So 13 into 6.
13 into 6. Just multiply by 6. Gives you the heart rate. Correct. Okay. That is it. Exactly. Perfect. Just how many small the QRS is there in the 10 seconds. You know how much. Then multiply by 6. That gives you the number heart rate. This is again approximate only. It is not 100 because it is an irregular rhythm. At this minute, in this ECG, this is the rate. Next 2 minutes later, the heart rate will be different because that is how the atrial fibrillation behaves, fast rate followed by a slow rate, suddenly jumping a rate. So it's irregular. In this ECG, given ECG, the heart rate is 78 per minute. How did you calculate? Beginning to end. How many big squares are there? That is 10 seconds recording. Multiply by 6 to get the 60 seconds recording. That is 1 minute recording. That gives you the heart rate. Right? Right, sir? Everybody you all know how to calculate the heart rate in the ECG?
Yes, sir.
The
Yes,
machine will
Yes, sir.
give.
Yes, sir.
Yeah, the machine will give. Don't worry. Machine, most of the times it will be correct. But you must know how it is arrived and how to get it, right? Suppose you don't have a computerized ECG machine. You just have an ordinary machine. You must know how to calculate it. That's it. If you are very clear about the heart rate, then we will go to the subsequent normal values of each wave. We have different waves, P wave, QRS, T wave, different segments, PR segment, ST segment, and TP segment. All those segments are there. We must know what is the normal value for each segment. That's what we are going to see today, right? Okay. You know what is the P wave now? The first positive deflection is the P wave. Then the next positive deflection is the R wave. The entire complex is called the QRS. In between the P wave and the QRS, you have a silent gap. I told you it is due to the AV nodal delay. AV nodal delay. Then ST segment and T wave. That's what we have told you. We will see what is the normal for each one of them and diagnose the abnormality from this, right? Okay. We will first take the P wave. You all know P wave represents what?
atrial depolarization.
Atrial depolarization. SA node has fired an impulse. That impulse has traveled through the atrium, and when it travels, it has depolarized the atrium. That is represented in the ECG as the P wave. Correct. So P wave represents atrial depolarization. So all your atrial abnormalities will be reflected in the P wave only, not in the QRS. You will diagnose only from the P wave only. Right. Now tell me which atrium? Right atrium or left atrium?
Left. Right, sir.
Both
Right.
it.
Both
Both,
atrium. It is
both,
both
sir.
atrium. Correct. Exactly. Even though the sinus node is there in the right atrium, but P wave represents the overall biatrial depolarization. Both wave. Usually they depolarize at the same time. So it represents biatrial depolarization. Okay, right. So which lead is the best lead to look for the P wave? The best lead is lead 2. Lead 2 is a beautiful lead. You will see all the P, Q, R, S, T, everything very nicely in that lead. That is why in all your cardiac monitors, we select lead 2 for recognizing. Because that will show the P wave very nicely, QRS very nicely, even small Q wave will be seen nicely like that. So when you want to diagnose an atrial abnormality, look for the P wave abnormality in lead 2, right? So how do you record, how do you calculate the P wave? How do you measure is, it is from the beginning of the P wave to the end of the P wave. This is the P wave. The beginning of the P wave to the end of the P wave. That is how you measure the P wave. So a wave, it is a wave, isn't it? So what does a wave means? It has two directions. One, the vertical, that is we call it as a amplitude. Vertically, it is amplitude. Horizontally, it is the duration. That is amplitude is what is the height of the P wave? What is the duration? How long it takes for the atrium to get depolarized? That is what the duration tells us. How long it takes. So the normal value of the amplitude is 2.5 millimeter. 1 millimeter is 1 small square. 1 millimeter is 1 small square. So the maximum height of the P wave, normal P wave, should be around 2.5, 2 small square plus another half small square, 2.5 small squares. Duration also, horizontally also, it is the same 2.5 small squares. So easy to remember. Remember 2.5, 2.5, both vertically and horizontally. Both ways, it should occupy only 2 small squares, vertically as well as horizontally. But it is difficult, this big small square itself is too small. We have to strain our eyes to look at it, and to identify half of it to calculate, it will be difficult. So approximately, you take it as 2 to 3 small squares. So the normal amplitude of this P wave is 2 to 3 small squares. Normal duration of the P wave is 2 to 3 small squares. Just remember this value. If you remember this value, you will diagnose all atrial abnormalities. No problem. Okay. So this is how. See from here to here. How many small squares are there? What is the amplitude here? From the baseline, you measure how many small squares are there?
2 small
2
squares.
small squares. What is the duration?
0.1.
Again, it's 1.5 to 2. That's all. Right? It is less than 3. Take it as 3. 2 to 3 is the normal value. It is less than 3. So what do you think? This is the normal P wave or abnormal P wave?
Normal.
Normal.
Normal
So what do
PV.
you understand by that? Do you think this patient will have a atrial abnormality, atrial dilatation?
No.
Normal, sir.
No, sir.
Isn't it? So if the P wave is normal, that means his atrium is normal. Very good. Excellent. So what are the clinical implication is, whenever there is a abnormal P wave, you have to suspect atrial enlargement. A big tall P wave, more than 3 small squares, or a wide P wave, more than 3 small squares, you should understand, diagnose that the atrium is abnormal. There is some problem with the atrium. The atrium is dilated. That is what we have to understand, atrial dilatation. And in that also, there are 2 atrium, left atrium and right atrium. Can we differentiate between the 2? Yes, easily. That is, if the abnormality is in the height, instead of 3 millimeters height, suppose it is 5 millimeters height, tall P wave, then you should suspect right atrial enlargement. If it is a tall P wave, suspect right atrial enlargement. If the problem is in the width, height is okay, only 3, but width is 5 small squares, then if the abnormality is in the width, suspect or diagnose left atrial enlargement. Simple. So you will not only diagnose the atrial enlargement, you will also say which atrium is enlarged, right atrium or left atrium. I will show you some ECGs. You tell me, is it a normal P wave? Concentrate only on the P wave now. Don't look at anything else. Do you think it's a normal? Which lead I told you to look at?
Lead 2.
Lead 2. So this is the best wave, lead. Okay. Concentrate on the P wave. Do you think it's a normal P wave or abnormal P wave?
Tall
P
PV.
wave.
Small.
Yeah. 2 too small. 2 up to 3 is normal. Even 1 millimeter is okay now. You suppose it's only 1 millimeter is okay.
Normal
Maximum is 3.
Normal, sir.
It is a normal.
Normal.
So it is a normal P wave. So it is a normal P wave. What do you understand? There is no atrial dilatation. We cannot say 100%. You cannot, because ECG is not 100% sensitive and specific for chamber enlargements. It gives you a clue. That's all. Sometimes there can be a normal ECG with enlarged heart. There can be an enlarged heart with the enlargement of the ECG with the normal heart in the echo. So it can happen. It is not 100% specific and sensitivity. This gives a clue. You diagnose there from this, get a clue to that. So it is a normal ECG. Very good. See here. What do you think? Concentrate on lead 2. I told you for P wave, look at the lead 2. What do you think this P wave is?
Right atrial
Enlargement.
Excellent. So it is abnormal P wave. Where is the abnormality? The abnormality is in the height. Is there any problem with
Amplitude.
Amplitude. Very good. Technically correct. Amplitude. Any problem in the duration? Width?
Yes, sir.
Width?
That's also
It's also increased.
3 squares, more than 3 squares.
Yeah,
4 squares.
Thinking 4. No, from beginning to the P wave to the end of the P wave, you have to calculate. See, this is the beginning of the P wave, end of the P wave. See, from here to here, it is 5 small squares. Here to here, it is only 2 or maximum 3, isn't it?
It's within normal limits.
So width is normal. Width is normal. There's an abnormality in the height. It's a tall T wave. We call it as a tall P wave. So what are the diagnosis here?
Right
Right
atrial
atrial
enlargement.
Right atrial
Right atrial
Super.
enlargement.
It is right atrial enlargement. Super. See here. See the tall P wave. Lead to tall P wave. As tall as the QRS itself. Moment you see that, you know there is a right atrial enlargement. Immediately you can say that. Very good. See this. Comment on this P wave.
This is left atrial enlargement. It's
Left atrial enlargement.
Super.
Duration is prolonged.
Wide
The problem is in the width, not in the height. So what atrial enlargement? Everybody has diagnosed correctly. It is a left atrial enlargement. Clear? Everybody clear? You can easily diagnose,
Yes,
right?
sir.
Any
Yes,
doubts
sir.
for anybody? Very good. Excellent. Great. See here. It is a bifid P wave.
Bifid P wave, sir.
Yeah. See, the problem is in the width. See here, from here to here. Both comprises of P wave. You must measure the P wave from the beginning to the end of P wave. See, it's almost about more than 3.5 small squares. So it is a wide P wave. Any problem in the width? I mean, in the height?
No, sir, same.
No
No,
problem. So it is a
No.
left atrial enlargement. That is what we call it as a P mitral. Which is the commonest condition where there is a left atrial enlargement?
mitral stenosis.
Mitral stenosis. See, mitral stenosis, typically you will find an M-like pattern. That is why we call it as a P mitral. We used to call it as a P mitral, which represents left atrial enlargement. Clear, everybody? Everybody clear?
Yes,
Yes,
sir.
sir.
Suppose you find some ECG where there is no P wave at all. Only QRS. What's your interpretation? Suppose you find QRS. There is no P wave at all.
Absent PPM atrial fibrillation, sir.
Yes.
Ventricular beats, sir.
It's only ventricular beats.
No.
Atrial beats is not happening. Atrial
No.
depolarization is not happening. That's what you have to understand, isn't it? There is no P wave at all. That means the sinus node is not either firing an impulse or the left atrium, the atrium is not getting depolarized. If there is a depolarization, there will be a P wave. So sinus node had fired an impulse, primary pacemaker has failed. That's what you mean. So when the primary pacemaker has failed, what will happen immediately? Which pacemaker will take over?
AV node.
Bundle of
AV node.
AV node.
Secondary pacemaker will take over, isn't it? It could be a junction, it could be a ventricle, or it could be even fascicle. There are 3 secondary pacemakers. So when there is no P wave, what you have to understand is the primary pacemaker is not doing its job properly. That's what you have to understand. SA node is not doing its job. Atrial depolarization is not happening, right? Right. It could be a sinus rest. Don't worry about it. See this ECG here. I told you the best lead is lead 2. Do you see a P wave anywhere?
No, it's not seen, sir.
Everything is QRST only. It's all QRST, everything is QRST only. Only QRS complexes. You don't see any P wave. The P wave should come before the QRS. You don't see any QRS wave, any P wave anywhere. Do you recognize this? Are you able to appreciate that there is no P wave here?
No PV.
Yes, sir.
Yes, sir.
Yeah. Everybody understands that there is no P wave happening. So what does it mean? The sinus node has not fired an impulse. It has not produced a atrial depolarization. Primary pacemaker has failed. Then how does it live? How does the fellow live? That's because of the secondary pacemakers taking over. Ventricle is taking over. Ventricle, this is a one ventricular beat. This is another ventricular beat. Another ventricular beat. See, the ventricular beat is doing it waits for the next sinus beat to come. The next sinus beat is not coming, so ventricular beat. Then again wait for the next beat, not coming, so sinus beat. Waits for the next P wave, not coming, ventricular beat. So that is called this is a secondary pacemaker rhythm. This is entirely a secondary pacemaker rhythm. So you don't see any P wave. That's what you have to understand. That means it is not fired an impulse. Everybody clear about the P wave? Normal values?
Yes, sir.
Right atrial enlargement?
Yes, sir.
Left atrial enlargement? No P wave. Right? Only 3 abnormalities can be there in P wave. Nothing else. So you have
Sir, What if P wave is absent only on few leads?
Yeah, we will tell you about it when we talk about the hard block. That's
Okay,
typically a
sir.
hard block. When we talk about it, the hard blocks, right? We will come to all those things, sir. Now let us understand basics first. Complicated everything you will learn that. You will be thorough in this. I will tell you subsequently as a future lessons, right? If I tell you something, you will get confused now. Right. What is the next after the P wave is the PR interval. You know, the silent gap between the P wave and the R wave. That represents, you all know, it represents the AV nodal delay. So by looking at the PR interval, you recognize the health of the AV node, whether the AV node is normal or abnormal. Is it doing its job properly or not? That's what we are going to diagnose from the AV nodal delay. So what is AV nodal delay? This you have seen already. Protect the ventricle from rapid supraventricular impulses, allow the atrium to complete its contraction, boost kick effect. These are the three purposes, right? Right, okay. So again, which lead is the best lead to recognize the PR? Once again, lead 2 only, because that is the lead where you see the P wave nicely, then PR interval also will be nicely seen only in that lead. So choose lead 2 once again for concentrating on the PR interval. So how do you record, how do you measure the PR interval? You record from the beginning of the P wave to the beginning of the QRS complex, from here to here. This interval is called the PR interval, beginning to the end. Sometimes you can also measure from the peak of P wave to the peak of R wave. Both will be almost be correct. Both ways are correct. But correct technique is from the beginning of the P to the beginning of the QRS is the PR interval. What is the normal value? How much it should? It is a flat line, isn't it? It is a flat line. So there is no question of amplitude. There is no height. It is just a flat line. There is no height at all. Only the duration. The width only matters. There is no P wave. There is a height. Whereas this is not a wave at all. It is only a segment. It is a flat line. So no amplitude here. Only the duration. What is the normal duration? It is 3 to 5 small squares. So from here to here, from beginning of the P wave to the beginning of the QRS, it should occupy only 3 to 5, maximum 5 small squares. 1, 2, 3. That's all it occupies. It can go up to 5 maximum. Right? That's what it means. In other words, how much is 3 small squares? 1 small square is 0.04. 3 small square is 0.02. 5 is 0.20. Technically, correctly, it is 2.1. But difficult to understand 2.1 measure and also for practical purposes, 3 to 5 small squares is the normal duration of the PR interval. Right? Suppose what abnormalities can happen? There cannot be any there is no height involved at all. It is only the duration. So what are the two abnormalities that can happen? Either the PR interval can become more prolonged, more than 5 small squares. Normally it should not exceed 5 small squares. Suppose it is 8 small squares, P wave to the QRS. Then we call it as a prolonged PR interval. Or minimum at least 3 small squares should be there. Suppose it is very small, 1 small square only between the P wave and the QRS. Then it is a short PR interval. So there are two abnormalities possible in the PR interval, a prolonged PR interval or a short PR interval. Suppose the prolonged PR interval means, what do you understand? Suppose the PR interval should be only 5 small squares. A normal healthy AV node should give a delay of only up to 5 small squares. Suppose it gives excessive delay. Excessive, it takes longer time to conduct the impulse from the atrium to the ventricle. That's what it means. So if it is doing it, that means the AV node is healthy. Unhealthy, I'm sorry. AV node is unhealthy, not doing its job properly. It is taking extra time to conduct the impulse. It is getting prolonged. So if the AV node is same thing. So if it is prolonged, if the AV PR interval is prolonged, that means there is a disease at the AV node. We call it as a AV block. The AV node is giving excessive block. That is what we call as a AV block or heart block. Your heart block, first degree heart block, second degree, third degree, everything. Where is the problem? It is at the AV node. So how is it represented in the ECG? Prolonged PR interval. If the PR interval is prolonged, the AV node is not doing its job properly. It is giving more delay than expected. That's what you have to understand. So always measure the PR interval. See whether it is within 5 small squares, right? If it is more than that, there is a hard block. There is a AV block, right? Okay. Sometimes if it is very short, one small square only, P wave immediately followed by a QRS. P wave immediately followed by QRS. Then what does it mean? The impulse
Firing it
is
up
not
faster.
going through the AV node at all. It is going to the ventricle through some other pathway. If the impulse is going through the AV node, it has to have a delay. The AV node will produce a delay. Suppose there is no delay at all, P wave immediately followed by a QRS without a PR segment at all, that means there is some other pathway through which the impulse is traveling straight from atrium to the ventricle. That is called the abnormal accessory pathway, extra pathway which some people have. The typical example is your WPW syndrome.
WP syndrome.
Wolff-Parkinson.
Delta.
Exactly. Super. Correct. Absolutely correct. Right. So now concentrate. Now try to interpret. Is this PR interval or normal or abnormal in this ECG? Look at lead 2. Measure from the beginning of the P wave to the beginning of the QRS. Do you think it's normal or abnormal?
The duration is shorter, sir.
Normal, isn't it? It's a normal PR interval. See, from here to here, how much it takes? About three small squares.
3 small squares.
See, it is a normal. 3 to 5 is normal. So what do you understand? The AV node is normal or abnormal? Diseased or normal AV node?
Normal.
AV node is healthy, doing its job correctly, giving the expected delay. Right, correct. Okay. See here. Again, choose the lead 2. That's the best lead. Measure the PR interval. This is the P wave. This is the P wave, QRS, T wave. P wave, QRS. Measure from the beginning of the P wave to the beginning of the QRS. Is it normal? How many small squares are there? How many small squares are there?
More than
5 squares.
8, 9, sir.
Yeah, approximately around 8 small squares.
8.
Exactly. So 8 means it's a prolonged PR. So is the AV node normal or abnormal? Diseased?
Abnormal.
Conduction delay.
Block.
It is block. It is definitely AV node
AV
is giving
block.
excessive delay. More than that it should give. It is giving excessive delay. So it is giving excessive block. We call it as a AV block or heart block. Got it?
Yes, sir.
Okay. Is the AV block. See the P wave. See your eyes will get tuned to it immediately. Moment within fraction of a second, you need not even count. It's a definitely prolonged PR interval, isn't it? But
Yes, sir.
just the look of it, see the PR interval here, see the PR interval here, and see the PR interval here. But just to look at it, you have already diagnosed a disease in the AV node. That's it. AV block, right? First degree, second degree, we will learn it later. Everybody clear, sir?
Yes.
Yes, sir.
Okay, see this PR interval. Normal or normal? This is the P wave, this is the QRS. This is the P wave, this is the QRS. Normal or normal?
Prolonged.
Prolonged. Abnormal.
Prolonged PR interval, AV node is
Block.
failing, not doing its job. Correct, super. This is what I meant as an accessory pathway. See, your sinus node is here, your AV node is here. From impulses should travel through the atrium, come to the AV node, suffer a delay here, AV nodal delay, that is the PR interval, then go to the ventricle. That is the normal pathway expected to do. But some people will congenitally have an abnormal wire somewhere here, a conduction system, a conducting wire directly connecting the atrium to the ventricle. So what happens is some impulses will travel through this also. When it travels through this, where is the question of PR interval? No PR interval. Just straight away, immediately atrium depolarizes, immediately the ventricle gets depolarizes. If it goes through the AV node, there will be a delay. When it is not going through, when it is bypassing the AV node, your PR interval will be very short. There will be no PR segment at all. P wave immediately followed by a QRS. That is called the short PR interval, which is diagnostic of an accessory pathway. Some abnormal pathway, extra pathway is there for the patient, which conducts the impulse directly from the SA node to the ventricle, not going through the AV node. That's what we have to understand. See this ECG. Look at here. Look at here. See this PR interval. Do you think it's normal or abnormal? Let's choose the lead one here. Lead 2 is not very clear. Choose the lead one here.
Abnormal, sir. Very low.
It's a very short PR.
No gap.
Again,
No gap.
there is no PR segment at all. P wave is immediately followed by a QRS. P wave immediately followed by QRS. There is no PR segment. There is no PR interval. PR interval is very, very small, less than 1 small square or even 2 small squares. So, moment you see this short PR interval, you should immediately diagnose the impulse is not going through the AV node. It is traveling through some other accessory pathway. Conduction system, right? Abnormal conduction system. Clear, sir? Everybody?
lead 2 clear ஆ பார்க்க முடியல அப்படின்னா நம்ம lead 1
Yeah, whichever lead that shows the P wave nicely, you can choose, no problem. Because it will be the same all through the ECG. Sometimes because of the axis of the P wave, you will not be able to see that in that particular lead. Whichever leads, usually the best lead is lead 2. Whichever lead that shows the P wave nicely, you can calculate. See here, nicely it is in here. P wave immediately followed by QRS.
Yes,
that's the short PR interval. The diagnosis here is straight away WPW syndrome. Very workable, nothing need to be done. Just fraction of a second, you will be in a position to diagnose your WPW syndrome. So what are the clinical implications? Why should you break your head to diagnose whether the AV node is doing its job, whether there is an accessory pathway and all? The idea is, if it is a prolonged PR interval, that means the AV node is getting excessive block, doing excessive block. So you should avoid beta blockers for this patient, because beta blocker will further suppress the conduction. Already the conduction is suppressed. Already the AV node is doing excessive delay. If you give beta blocker, the delay will even be more. You will be worsening the disease. So that is the clinical implication. You should avoid beta blocker for such. You should not start beta blocker, or if the patient is already on a beta blocker, you have to reduce the dosage of beta blocker. Many times, beta blocker will be the culprit for prolonged PR interval. Many patients from tomorrow you see who are on high dose of beta blocker for a long time, you will find the prolonged PR interval there. Many times, beta blocker will be the culprit there. Try to identify the cause and treat, frequent follow-up. Whereas if it is a short PR interval, you have to give beta blocker. That is the difference between the two clinically. If it is prolonged, you should not. If it is short, you should give beta blocker. Why should you give beta blocker? Otherwise, they are prone for SVT, supraventricular tachycardia. Anytime, people with WPW syndrome can go for a SVT, and it can be fatal also for those patients. So all your short PR interval patients, you have to give a beta blocker to prevent a tachycardia for these people. So that is the clinical difference between these two. If it is a prolonged PR interval, avoid or reduce beta blocker. If it is a short PR interval, you have to give beta blocker. That's the difference between the two. That is why you have to carefully look for it and apply that information into your management section. Okay, clear? P wave you are clear.
Yes.
PR interval you are clear.
Yes, sir.
Any doubt for anybody?
No, sir. Clear, sir.
Very clear. Okay. Now we will go to the next wave, the QRS. The QRS, that's the king of ECG, QRS wave, right? QRS represents, it represents the ventricular depolarization, right? Okay. So how do you measure QRS? The ideal lead will be V5 and V6. That will show the QRS nicely. How do you measure is beginning of the Q wave, not from here. You must start from here. Beginning of the Q wave to the end of S wave. That is how you must measure the width. Beginning to the end. And how do you measure the amplitude? From the baseline to the tip of the QRS wave. This is the amplitude from the baseline to the height is amplitude. The duration is beginning of the Q wave to the end of S wave. That is the duration. Okay, this is the normal QRS. So, we don't give much importance for the height of this QRS, because the height of the QRS can vary for different people on various normal physiological conditions. For example, somebody has a very thin chest wall. His QRS will be very big because the ECG machine will pick up the voltage so nicely because of the very thin chest wall. The QRS will be very tall. Doesn't mean that he has got a disease. For example, somebody has a very obese fellow, obese, thick chest wall. The QRS duration will be smaller. Suppose there is a pericardial effusion, some fluid covering the heart, then the QRS will become normal, shallow, smaller. Suppose somebody has a pleural effusion, emphysema. If anything is interfering, the electricity getting transmitted to the surface, anything obstructing it, make the QRS low, shorter. That is the reason we don't give much importance for the height of the QRS. But anyhow, there should be upper limit. You cannot accept every QRS as normal. There should be an upper limit. So the upper limit is in the chest leads. That is, what are the chest leads? V1, V2, V3, V4, V5, V6 are the chest leads. In the chest leads, it should be the height of the QRS should be less than 26 millimeter. From the base to the tip should not occupy more than 26 small squares. One small square is 1 millimeter, isn't it? So 26 millimeter is 26 small squares. If it is more than 26 millimeters, you should suspect ventricular enlargement. Just like P wave, if it is very big, we suspect a ventricular atrial enlargement. Same way, QRS, if it is very big, you should suspect ventricular enlargement. The upper cutoff is 26 millimeter on V5, V6, chest leads. Limb leads, we cannot do any calculation because it depends on the axis of the heart. I will teach you subsequently the axis. You will all become masters in the axis at the end of the class, I tell you. So don't worry. So you measure the QRS only in the chest leads, especially V5 and V6. Upper limit is 26. So it is a wave. It has two components. One is the amplitude, another is the width. So we give importance only for the width. That is very, very important. What are the normal width? It should not be more than 2 small squares. Say from the beginning of the P wave, Q wave to the end of the S wave, horizontally, it should not occupy more than 2 to 3 small squares. That's all. It should occupy 2 small squares is the correct. 80 milliseconds or 0.08 seconds. That is 2 small squares. That's all the width of the QRS. If the QRS is wider, we call it as a wide QRS. It is a pathology. If it is within the 2 small squares, we call it as a normal narrow QRS. It is normal QRS, no problem. So you have to concentrate on the width of the QRS and not the height of the QRS. Of course, you should also concentrate, but more on the width. That is where a lot of significance is happening. It should not occupy more than 3 small squares. See, this width should not be more than 3 small squares. So why some impulse or why some QRS are thin and why it should become wide? It's because if the impulse is traveling exactly in this specialized conduction system. What is the specialized conduction system? AV node, bundle of his, right bundle, left bundle, anterofascicle, posterofascicle, Purkinje fibers. That is the path in which the impulse is supposed to travel. If the impulse is traveling exactly in that path, then the QRS will be narrow. Because the impulse is conducted at a very rapid rate in this specialist conduct, like your copper wire, electrical wire. Copper wire will conduct the electricity very fast, whereas wood will conduct it very slow. Like that, it is like a copper wire of the heart. So if the impulse is going exactly in the prescribed specialized conduction system, your QRS will be narrow. Suppose there is some block. For example, your right bundle branch block, your left bundle branch block. What does it mean? That branch is blocked. So that impulse cannot travel in that branch again. If the impulse is getting blocked somewhere in the specialized conduction system, and instead of traveling through the specialized conduction system, it has to travel through the muscle, then it will go slowly only. It cannot go that speed fast. So it will go slowly only. If the impulse is traveling slowly, then the QRS will become widened. So what is the clinical implication? If the QRS is narrow, what is that 100% you can say? There is no problem anywhere in the conduction system, no conduction block anywhere. The impulse is traveling perfectly along the pathway, so your QRS is narrow. If the QRS is wide, what can you 100% say? There is some block somewhere. Without that, the QRS cannot become wide. So narrow QRS tells you that the impulse is traveling along the specialized conduction system without any block. If it is wide, that tells you that there is a problem or a block in the conduction system. It could be at the bundle of his, it could be the left bundle, it could be the right bundle, anywhere. We will teach you subsequently how to recognize that. Right. QRS, whenever the impulse travels through the specialized conduction system, the QRS duration is normal or the QRS will be narrow. If whenever the impulse travels through the non-specialized conduction system like muscle, then the QRS duration is wide. That's all. So from the QRS, what you will diagnose is there any conduction block? Any block anywhere? That's what you have to diagnose from the QRS. Right. What is the clinical implication? If it is a narrow QRS, 100%, you can swear on anything. There is no distal conduction block. 100%. You can promise on anything. Nothing, no problem. If it is a wide QRS, you can again promise on everything. There is conduction block. Definitely. Without a conduction block, the QRS cannot become wide. So that also you can show. Suppose there is a very tall QRS or a very deep QRS, you should suspect ventricular enlargement. As I told you, ECG is not 100% specific and sensitive for chamber enlargements. So whenever chamber enlargements are suspected from the ECG, you must always confirm it with the echocardiogram, right? All the time. Right. Now, come to the QRS. Try to interpret this QRS. You concentrate on the V5 and V6. Let us say V6.
Quite normal, sir.
Amplitude, what is the amplitude? How much is the amplitude? 5, 10, I think it's not very clear. About 15, 5, 10, 12, 13, 14, right. Amplitude. What is the upper limit?
26.
26.
Yeah, everybody please attempt. You will remember it, right? 26, right? So is it within that or more than that?
Within that.
So what is the possibility? Probably there is no significant ventricular enlargement. Correct, everybody? You are sure? Yes? Yes or no?
No,
Yes, sir.
Yes, there is no possibly there is no ventricular because the QRS amplitude is within normal limits. It's only about 15 or 16. So probably there is no ventricular enlargement. If it is a ventricular enlargement, the QRS will be very high, very tall. It will occupy more than 26 millimeters. It will be up to here. So because it's normal height, you are almost not thinking in terms of a ventricular enlargement. Look at the width. Beginning of the QRS, end of the S wave. Is it normal or abnormal? It's a narrow QRS or a wide QRS?
Narrow.
Normal.
It is a narrow QRS. So what are you sure about? There is no conduction.
No conduction.
No
block.
conduction.
No conduction.
No conduction block. Absolutely. The impulse is traveling along the prescribed path. Right. Concentrate on the QRS here. V5, V6. Look at the amplitude. Look at the width. Is it abnormal?
Yes.
V5.
This is
Is it abnormal high QRS or let's say, for example, let us say here. See here. Just for understanding. Is it normal QRS or abnormal QRS?
abnormal, sir.
The amplitude is very high, sir.
Very high. See here 5, 10, 15, 20, 25, 30, 35, 35 small squares. So it is a tall QRS. So what do you suspect here?
Ventricular enlargement.
Ventricular enlargement. Probably this patient has a ventricular enlargement. Very good. Look at the duration. Is it a narrow QRS or a wide QRS? It's a narrow QRS. Just 1 or 2 small squares only, right? So it's a narrow QRS. So now you suspect a ventricular enlargement. You have ruled out a conduction block. Correct?
Yes.
Correct, everybody? Agree?
Yes, sir. Yes, sir.
Yes. Very good. Very good. Now look at this QRS. Concentrate on V5, V6. This is V6. Is it a normal QRS or abnormal QRS?
Abnormal.
Abnormal. Very good. What is the abnormality? Is it in the height or the width?
It's in the
Width.
Width. Very good. So do you think this patient has got a ventricular enlargement?
There is some
No, no.
No, unlikely. We cannot say no. It's unlikely. Very good.
Okay.
What is the width? Is it a white QRS or a narrow QRS?
White
Right.
QRS.
Very good. It's a white QRS. So what's your diagnosis now?
Some conduction block
There
is
is some conduction block. Definitely, the impulse is not traveling through the conduction pathway. It is going through some other pathway. It is going slow. That is why QRS is white. Clear, everybody? So easy. You can diagnose conduction block so easily, right? Very good. It's a conduction block. See this QRS. Concentrate on the B6, B5. Normal QRS or abnormal QRS? Narrow
Abnormal.
QRS or white QRS?
white QRS.
So
White.
you don't need
Abnormal
much
white
time.
QRS.
That's why made a fraction of a second by just looking at it. You have
Conduction.
diagnosed white QRS, you have diagnosed by block, conduction block, so many things. Within a second, fraction of a second, you can diagnose. You have to get trained to it, that's all. Right? It's a white QRS, natural. But please understand, what do you think about the amplitude? Amplitude is normal or abnormal?
It's
Normal.
half the normal, sir. It's only 5.
Half the normal.
Very good, excellent. Excellent.
Standardization.
Exactly, super. Always, whenever you are concerned about the height, you must concentrate on the standardization. Your height, calculation, everything will be correct if only it is a normal standardization of 10 millimeter. See, it is only 5 millimeter standardization. 5 millimeter standardization. So, I told you it is not only a height, tall QRS, it is also a deep S wave is also equal to chamber enlargement. See this QRS, the S wave. This is the S wave, isn't it? See how much, what is the depth here? 5, 10, 15, 20, around 30, around 25 to 30. It is equivocal. For example, here you take 1, 2, 3, 15, 15, it comes to 15. You will think that 15 is normal, it's unlikely that there is some chamber enlargement. But where is the problem? It is the standardization here. It is half standardization. In half standardization, it is 15. Suppose it had been recorded in normal standardization, it would be 30. It will be 30, right? So it is actually this patient has got a ventricular enlargement, significant ventricular enlargement, but ECG is not suggestive because it is recorded in the half standardization. Why? Some technician would have understood that you had recorded it half standard, or the machine itself will recognize that it has to record in half standardization. Otherwise, the QRS will go one above the other. See here, it is already going one overlapping with each other. So to avoid this, the machine itself has recognized this and is recording it in half standardization. So the caveat is wherever you are calculating the amplitude, look at the standardization. Wherever you are calculating the width, look at the speed. Very important. Suppose it is recorded double the speed, even the narrow QRS will be wide, double the width. So that is the importance of standardization. I always tell you. What do you think? This QRS is normal or abnormal QRS?
It's widened, sir.
White QRS. What is the problem? The conduction block is there or not? You should not take this time. White
Yes,
QRS,
there is a
yes, conduction block is there, no doubts. Immediately you can say there is a conduction block, right? There's no doubt at all. White QRS means conduction block, no doubts. The other abnormality that can happen in QRS is sometimes you will find low voltage complexes. See this, all these QRS are very small, very small, very small, not like the previous ECGs. So what are the criteria to call is it as a low voltage complexes is QRS amplitude less than 5 millimeter in limb leads. Limb leads are lead 1, lead 2, lead 3, AVR, AVL, AVF. All the 6 leads, the amplitude should be less than 5 millimeters. And in the chest leads, it should be less than 10 millimeters. If it satisfies this criteria, then you call it as a low voltage complexes. Commonest clinical condition where there could be a low voltage complex is a pericardial effusion, hypothyroid state, huge obesity, and other massive pleural effusion, all those things you can think. That's called the low voltage complexes. So there's the criteria. Limb leads less than 5 millimeter, chest leads less than 10 millimeters qualifies for a diagnosis of a low voltage complex.
low voltage.
Right? Right. The other possibility is normally in all these ECGs we see you will see gradually the R wave increasing. See here, lead 2 R wave is more, lead 3 V R wave is more, V4 more 5. So there is a gradual progression of the R wave steadily. That's called the normal progression. But sometimes you will see that there is no progression of the R wave at all. See, the lead one is V1 is here, V2 there is no R wave, V3 again no R wave, V4 no R wave, V5 no R wave, V6 no R wave, everything only Q and S wave, Q and S wave, no R wave at all. If you see that, we call it as a non-progression of the R wave. Normally, the R wave should progress from a small height to bigger height. If it is not progressing as expected, we call it as a non-progression of the R wave, which is a sign of old infarction. Old infarction. That means there is no healthy muscle there. So that's a old infarction. You will understand it better when we talk about the infarction class, infarction class. So this is another pathology that can happen in QRS, non-progression of the R wave. That's called the it is a sign of infarction, old infarction. So we will stop here. I think it's more than 1 hour, 2 minutes of information today, right? Are you clear about the P wave heart rate calculation? Any doubts?
No, sir.
Regular rhythm,
No, sir.
irregular
Yes, sir.
rhythm. If no, your P wave, tall P wave, right atrial enlargement, wide P wave, left atrial enlargement. If there is no P wave, no firing by the primary pacemaker. That's about the P wave. PR interval 3 to 5 small squares, more than 5 small squares, prolonged PR interval, AV block, hard block. If it is a narrow, short PR interval, accessory pathway, usually WPW syndrome. There are other pathways also. You will have a separate class for that. Okay. Then in the QRS, amplitude 25 millimeters in any lead, 26 millimeters in any lead. More than that, suggest a ventricular enlargement. Width is more important. Narrow QRS is less than 2 small squares. Anything more than 2 small squares is a wide QRS. Wide QRS tells you that there is some block in the conduction system somewhere. At the end of this course, we will precisely say where is the block. I will teach you all that. But now, at this point of time, understand there is some block somewhere, right? Conduction block. If the QRS is narrow, there is no block at all. 100% the conduction system is intact. If the QRS complexes are very small, less than 5 millimeter limb leads, less than 10 millimeter chest leads, we call it as a low voltage complexes. If there is no progression of the R wave, that's a sign of infarction, old infarction. That's all about the PQRST. I'm sorry, PQRS. That's it. Any doubts? Clear?
Yes, sir.
Yes, sir.
Yes.
Only 3-4 people are responding. Why?
Yes, sir.
What else
Clear,
are
clear,
there?
clear.
Yes, sir.
Yes, sir.
Clear, sir. Clear.
Because I want you to be 100% clear in this. This is the basis of all your ECG learning. If you forget it or if you don't understand it, it will be difficult to understand ECG. Clear, everybody? Shall I take it as clear? Okay.
Yes,
Yes,
sir.
Clear, sir. Yes, sir.
Okay, thank you. I'm sorry I have taken some extra time, but this goes on. Invariably it happens. You should not be very time conscious. You should understand what you are talking.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Okay, welcome.
Thank you, sir.
Welcome. We'll close.
Thank you, sir.
Tomorrow we have 2 guest lectures. 2 guest speakers. First topic will be on urinary tract infection, which is a very, very common thing which we come across in our day-to-day practice. Urinary tract infection. The second topic would be on the sexually transmitted diseases. Though not that common today, we have to know what it is, right? So both the topics are going to be dealt by eminent speakers in the field. So please join on time, 8 o'clock. Please be there. We cannot wait the guest speakers to wait for a long time.
Yes,
Please
sir.
join on time.
Okay, sir.
And with tomorrow, we will be closing the infectious disease module. I think we have covered most of the common important infections, right? Then from Sunday onwards, that is coming Sunday, that is 12th, we have a direct class at Chennai. Please do attend, don't miss. Attending a direct class should be a pleasure by itself. Don't miss that. And we will be starting off with the cardiology module, which is very, very important module. They have very interesting lectures scheduled for the day.
Okay, sir.
So block your date, make your travel plans, everything. If you want the rooms, accommodation, call Mr. Moidin. He will arrange for the Moidin or Mr. Ranjit. He will arrange for your accommodation. We will be starting the class at 9:15 on Sunday. Okay, right.
Yes, sir.
Bye. Good night, all.
Thank you, sir. Good
Good
night.
night, sir. Thank you.
Thank you. Good night,
Thank
sir.
you, sir. Good night, sir. Thank you.
Night, night, good
Thank
night,
you,
all.
sir.
Night, sir.
Good night, sir. Thank you, sir. Thank you, sir.
Good night.
Thank you, sir.
Thank you, sir.
Was the class useful to you? New informations or everything known to you already?
Useful, sir.
Okay. Thank you.
Useful.
Positive,
Thank you,
without
sir.
any.
Thank you.
Thank you, sir.
Thank you, sir.
Welcome. Good night. Bye. Good night.
Thank you, sir.
Good night. Enjoy your dinner. And stop sharing.